Welcome to the second part of Activity 7, Identifying Drug-Related Problems. In this second installment, I will be talking about the details of the drug-related problems, merging the two learning resources from the book of Sepulay and from PCNE. Please grab a copy of PCNE version 8 for reference during the discussion. The codes in the causes domains are used in the merging of DRPs categories from the two resources. Starting from this section onwards, please refer the codes from the PCNE version for descriptions. The first DRP is on unnecessary drug therapy. It has the same thoughts of code C1.1 to C1.7 and C2.1. Unnecessary drug therapy is possible if there is multiple drug products that are being used for a condition that only requires a single drug therapy. Also, drug therapy deemed unnecessary if there is no medical or valid medical indication for the therapy, and the medical condition can be treated with non-drug therapy. Also, if the patient's problem is caused by a drug abuse, alcohol use, or smoking, hence, those things should be omitted from the patient. And also, if drug therapy is being taken in order to treat an avoidable ADR, hence therapy is unnecessary. In order to address this one, the drug that causing ADR should be omitted from the patient therapy. The following is a list of common causes of drug therapy problems involving patients who are taking unnecessary drug therapies. These common causes of drug therapy problems are listed in order of frequency of occurrence in practice. These drugs are the vitamin E, vitamin C, omeprazole, aspirin, multivitamins and minerals, folic acid, omega-3 fatty acid, vitamin D, ibuprofen, and metformin. This second DRP talks about the need for additional drug therapy. Additional drug therapy is required to treat or prevent a medical condition or illness from developing. That is called preventive drug therapy. Also, if a medical condition requires an initiation of a new drug therapy. A medical condition requires additional pharmacotherapy in order to attain synergistic or additive effects. Patients taking no medication can have a drug therapy problem. Prevention chronic medical condition is a major objective of pharmaceutical care practice. As new and innovative drug regimens are designed and demonstrated to be efficacious at preventing many diseases, it is important that patients receive appropriate preventive medications. The following is a list of common causes of drug therapy problems involving patients who require additional drug therapies to meet their needs. We now have confirmed evidence that daily low-dose aspirin can use prevent secondary heart attacks or myocardial infarctions and or strokes in patients with certain risk factors. There are numerous trials demonstrating also that fractures and other injuries can be minimized by the use of daily calcium and vitamin D supplements to slow prevent bone loss or osteoporosis in women. Safer and more efficacious immunizations are constantly being developed to prevent serious infectious diseases including measles, mumps, rubella, influenza, and hepatitis. Also, we have here filgrastim in order to prevent infection for patients receiving chemotherapy regimens. And we have sunscreens to prevent sun-induced skin disorders, dimenhydrinate for motion sickness, amoxicillin is only for preventive or for endocarditis prophylaxis in patients or dental patients with cardiac lesions or prosthetic valves. Colchicine is a prophylaxis for frequent attacks of gouty arthritis. Propranolol is also prophylactic treatment for recurring migraine headaches, and atorvastatin is primary prevention of CVD in patients with multiple cardiovascular disease risk factors or diabetes. The third DRP is about ineffective drug. It has the same thought from the PCNE version 8 C1.1, C1.2, and C2. Effectiveness can only be realized if an appropriate drug product is selected and the dosage used is sufficient to produce the desired outcome in a particular patient. The drug product is not being effective at producing the desired response or outcome if it does not treat the indication that being treated. Choosing the drug regimen that will be most effective for an individual patient involves an important set of clinical decisions. Also, drug is deemed to be ineffective if the medical condition is refractory to the drug product, or if the dosage form of the drug product is inappropriate, and there is also contraindication present. The drug is not effective for the medical problem as it should be. It is important to keep in mind that if a drug product has been demonstrated to be efficacious in 75% of patients with a certain medical condition, then it is likely that 25% of your patients with that same condition will not respond positively. Therefore, even if a drug product is thought to be the first-line therapy or the drug of choice, it will not be effective for all patients. Drug-related problem number 4. Dosage is too low. It has the same thought for PCNE version 8 C3.1 and C3.3. The dosage is too low to produce the desired response or outcome. The dosage interval is also too infrequent to produce the desired response. There is incorrect administration of the drug producing a dosage that is too low. And also, there is a drug interaction that reduces the amount of active drug available. And there is incorrect storage of the drug, which produces dosage of drugs that is too low in the body. And the duration of the drug therapy is too short to produce the desired response. These are the things that makes a dosage too low and causes drug-related problems. Example, if the patient has 10 mg daily of glipizide, is too low to provide adequate control of her blood glucose, the most frequent drug therapy problem associated with lack of effectiveness is seen in patients who receive a dosage regimen that is not sufficient to produce the desired pharmacological result. A dosage regimen has multiple parts and includes the drug product, the dose, the dosing interval, and the duration of therapy. All of these components must be appropriate for the patient in order to produce the desired outcome. Too often, patients are given a drug product that is considered to be efficacious in a population, but the dosage regimen is not sufficient to benefit the individual patient. Making certain that the patient are taking an adequate dosage of their medications to produce the desired effects is a responsibility of the clinical pharmacist. One size does not fit all, and one dose does not work for all patients. So we need to understand, clinical pharmacy students, you have to understand that the published dosing guidelines that we have now in the internet are usually generated through highly controlled research studies and therefore can only be used as initial guidelines for drug dosing. Patients will require varying amounts of medications in order to produce the desired pharmacological effects. There are also many instances in which patients are started on drug therapies using a very low or conservative dosage regimen in order to see what happens. This logical and often safe approach requires the doctors to be fully committed to follow up at scheduled intervals, to evaluate patient status, and to make any necessary dosage adjustments. that also need a clinical pharmacist in ambulatory care. Without this critical follow-up evaluation step, the patient is destined to suffer unnecessary periods of inadequate treatment and then continued illness if the dosage received is too low to produce the desired outcome. Similarly, also, patients may not be taking the dose of a drug product often enough to fully realize the benefit. If the dosing interval is too prolonged, the beneficial effects of the drug may disappear before the effects of the next dose appear. Hence, adjusting the dosing interval is a common intervention to resolve some drug therapy problems. These are the 10 drugs most frequently prescribed for patients with doses that were too low to achieve the desired goals of therapy and therefore did not achieve the intended positive outcomes. So we have here insulin, metformin, gabapentin, lisinopril, exenatide, simvastatin, furosemide, fluticasone, hydrochlorothiazide, and sertraline. Note that these are all drug products that are used very commonly in practice and for which there is considerable evidence of their efficacy and considerable dosing information available. Nevertheless, patients continue to be treated with inadequate dosages, resulting in continued morbidity and mortality. What seems to be missing from our healthcare system is the application of rational, comprehensive, and effective method to ensure that each of our patients receive drug therapy at a dosage likely to produce the